Good morning or good afternoon. This is Dr. David Nace, Chief Medical Officer here at Innovacer. We are just getting assembled for our webinar. I see folks are coming on. We'll just give it 1 minute here to allow us all to get assembled, and then we'll get started. Great. Well, welcome to the webinar, Virtual Care, Sustaining the Change During this Pandemic, the perspective of providers, payers, and the ATA, which we'll learn a lot about. So first, I just want to welcome our panelists, and we'll start off here on the left. Beth Bierbauer, former President, Group and Specialty Division at Humana and an ATA board member. Beth, welcome.
Great to be here.
Awesome. And Dr. Joe Kevdar, Professor, Harvard Medical School, Senior Advisor, Virtual Care, Partners Healthcare, and President of the ATA. Joe, great to have you on board today.
And thanks so much for inviting me, David.
Awesome. Ann Mon Johnson, Chief Executive at the ATA. You're getting a lot of attention today, and I would imagine you have a lot to say. So welcome, Ann.
Thank you so much for having me and all of us.
Great. Let's get started. So obviously, we've all experienced this pandemic. The healthcare impact has been quite significant. There's been more than $6 trillion spent in this battle to date. There's been shortages we've been battling with of medical professionals that are experienced, PPE, ventilators, intensive care units. Case volume continues to increase in certain regions, and the pandemic has really opened people's minds to new ways of innovation. So with that, let's get into that innovation. So Joe, as president of the ATA, and I know that you've testified before the Senate, we'll get into that in this webinar today, but there's been a change, right, with providers suddenly turning to telemedicine during this pandemic.
Yeah, it's extraordinary, David, and great way to lead off the discussion. I think the main thing is that telemedicine, telehealth is now a household word, which for me is an amazing thing. I've been explaining it my whole career, and I don't need to do that anymore. But in our own delivery system, I'll just give you our stats, and everyone that I've talked to in the provider side has had similar experience. My organization is comprised mainly of the Brigham and Women's and the Massachusetts General Hospital here in Boston, with satellite community hospitals and the like. In February, we did across the system 1,600 virtual encounters, and we're up to 60,000 a week now. Gradual increase over that time, and it's been extraordinary. And I think patients are generally quite pleased. That's my biggest excitement, and the doctors have come on board. A lot of them that were cautious or skeptical or puzzled by the whole thing before have just leapt into the pool with both feet and are doing great.
And I would imagine this has given your attention a bit of given your organization a bit of attention. Like, what has that been like for you?
Well, I tell people we're the sexiest, hottest association in town. So I think that it's important to remember that the ATA has been around for over 25 years, and it was started by the pioneers who really began this industry of telehealth. And when I joined them just over 2 years ago, it was pretty clear that adoption and engagement was pretty low by both clinicians and consumers. And so what happened with the pandemic was that telehealth, which was typically only associated with synchronous communication, video visits or phone video, really took off, as data will indicate that I know you're going to go through. And so what's happened with us is that, number one, it's been an amazing resource for our members who are making their own telehealth services available, but also we're seeing an incredible surge of asynchronous use modality where it's chat-led or interactive assessments, and then remote monitoring has just been amazing. So we're seeing telehealth in all its glory, and it's really fun to work for an amazing industry.
That's great to hear, and so exciting, I think, from both of you. You know, Beth, you're all three obviously are involved with ATA at this point, but you spent a lot of your career on the payer side. what have been some of the challenges or opportunities that you've struggled with from a payer perspective?
Well, adoption, as Ann had pointed out earlier, prior to COVID, a lot of folks really couldn't reach their physician via telemedicine, and most people, when they need care, want to go to their physician. So now that most primary care physicians and other physicians have really stepped in and begun to take advantage of these services, I think you're going to see this uptick really be sustainable in the future. But that would be probably, and from my standpoint, one of the biggest challenges that you had is, hey, my physician just didn't have the technology.
Well, that's great comments, and this has been so insightful as to some of the challenges. Today, we're going to talk a little bit about what has really worked to have this telemedicine, telehealth, virtual care adoption during the pandemic. We'll talk about the challenges, and we'll get into the future, and I think we're excited to hear about the future. So let's first start talking about what has really helped with adoption during this pandemic. And let's start with you, Joe. I know you're a practicing dermatologist within the partner system, and you've also recently testified to CMS. We'll get into kind of what you saw there for the future, but what has worked from a CMS perspective to date to make the adoption really helpful?
Thank you. So one thing I would give a shout out to Seema Verma, the CMS administrator. Prior to this, she was by far and away the most telehealth friendly person we've had in that chair, at least in my career. And so right away in middle of March, the federal government made some very important moves. One is they removed the originating site restrictions, which used to be a big impediment in terms of Medicare reimbursement. So now I can provide care to a Medicare recipient wherever that person is, in their home and wherever they might be, and I don't have to be in an office to do it. That's a huge thing. And then they started reimbursing us for everything: video, telephone, asynchronous, you name it. They started paying for it, and most states followed, often by governor decree. In Massachusetts, our governor said, you're going to do that, and actually, as we've reopened the economy, he continues to say you must offer telehealth first, which I think is an extraordinary comment. So reimbursement was one. The second was technology, which we can, I'm sure, talk about at some point, but all of a sudden we forgave HIPAA for a few months so people could use any technology. And then the third was licensure. Now, 49 out of 50 states have relaxed their licensure requirements so that people can practice across state lines. Really, those are the three big things, I think, that really pushed adoption fast.
So government's really helped, it sounds. And Beth, from your perspective, it sounds like some of the commercial payers have been receptive as well.
They have. This has really been a unique opportunity where you've had government payers and providers who have all really come together to ensure that people have had access to care. So, kudos to all parties, but payers have said, we're going to go into this full throttle. We're going to waive co-payments. We're going to make sure that people really have access. And so that's really helped that they've all really jumped on board.
This is really awesome. Joe, I know you made this comment about technology and the investment made. This is a recent survey from an investment advisory firm that showed the total percent of IT spend within a healthcare system with provider. And look at how much it revved up in March. I mean, that's 3 or 4-fold, right, of their total IT spend, which is extraordinary. Living in a healthcare system, what do you make of that?
Well, we even are talking about an interesting term that came up called technical debt. So we rushed to do all of these things, and sure enough, we did a full integration of Zoom into Epic pretty much overnight. So that's one example. But there are also things that we are doing that human beings are doing that technology should, because we had to just get going. And we figure the next 6 months we're going to be repaying that technical debt. So we'll be spending even more. And all of that in the context of an organization that's losing hundreds of $millions a month. So it's a not easy time. I mean, it's an exciting time from a telehealth perspective, but from the whole system of care perspective, it's a dicey time.
Yeah, it's quite extraordinary. And this is a survey that McKinsey recently did around all these different aspects of virtual healthcare applications. So it's not just telemedicine like a Zoom visit. There are other aspects of engaging people beyond just telemedicine, telehealth. We'll get into that terminology in a minute, but Ann, I would imagine from your perspective, you've been thinking as an organization how to broaden this concept of virtual health applications.
Right, and you know, the data has really been stunning in terms of how providers have invested, as well as, you know, organizations' delivery systems. One thing that I think is really important to note is, again, from a semantics perspective, we typically thought of telehealth as only synchronous communication, audio, video. And as you see here in the second category, the asynchronous telemedicine, what that did was allow delivery systems as well as physician practices to scale their response in a very efficient fashion. So you recall at the beginning of the pandemic, people were incredibly frightened. They weren't getting very clear information or direction on what to do. And what these asynchronous tools did, which were offered by a number of delivery systems and physician practices, enabled a consumer to use their computer or their smartphone to basically, or their phone basically, to interact and figure out whether or not they had symptoms that were consistent with the virus. And if they did, what they needed to do about it. And it didn't mean they weren't allowed to talk to a clinician. It just helped us flatten the curve and really stagger the response in a way that was responsive to consumers, but also really address the surge that was hitting the brick and mortar facilities.
No, it's great comments. And, you know, I think this terminology can get very confusing. You know, I would imagine, Joe, when you were in front of the Senate Help Committee virtually yesterday, I know it was a virtual presentation, which is great. These terms are not necessarily well understood by the general public. Walk us through kind of how we should think about this terminology.
Sure, and I would say that this field industry has been plagued by a new term every couple of years since I started working. So when I started, telemedicine was a cool term, and then it was telehealth, and then it became e-health, m-health, connected health, digital health. Recently, someone said to me, the new term is distributed health. So it's a little bit like pulling your hair out, to be honest with you. But this is a fairly, and I think, useful taxonomy that you have in front of us, which is that virtual care is this conceptual idea that it's anywhere where patients and doctors aren't together in a room. So anything comes under that banner. What we've thought of over the years is that telemedicine is very specific to medical care, to clinical interactions with our patients, and that telehealth is a broader term, which can include things like teleeducation and other uses of the same technologies to do other healthcare related things. So that's I think a fair current taxonomy that's in front of you there.
That's a great walkthrough. Well, I think our audience has largely been experiencing the adoption of these tools. Let's check in with them for a minute and take a quick poll and see, for each of you that are attending in the audience, how did the pandemic really impact your organization's virtual care strategy, thinking about this terminology? So we'll pull up that poll. Just go into the text box when you see it come up, and you can answer to the poll results as they present themselves. The questions are, was it negligible, since you already were well along the way with a robust virtual care strategy? Are you currently scaling up your telemedicine and finalizing your overall strategy given the response to the pandemic? Or are you just now figuring out what that strategy should be and looking for a new telemedicine solution? So while we're bringing that up, Ann, you've got a lot of different members of your organization. You look at it from a policy standpoint. You also look at it from a landscape, payers, providers across the country. What are you hearing today around where people are and adopting to this sudden surge in response and interest?
Well, I think, as you said, it's a really diverse membership within the ATA. We have delivery systems, academic medical centers, a handful of payers, as well as solution providers. And the solution providers range from, you know, the big leaders in the industry like Amwell and Teladoc Health, to other organizations like Hypnosis that white label their tools for delivery systems to make them be able to scale and offer a telehealth solution. Conversa Health and Babylon Health, which are much more AI dependent or driven. And then companies like Livongo, which has really taken a lead in terms of remote monitoring and remote care. So it's a huge gamut. And what has been consistent in all of them is that they're very interested in clearly doing the right thing for the community at large. And I think that one of the things that's helped with, or that's been interesting about telehealth or virtual care, is that it's not just clinician to patient, but it's also clinician to clinician. And so there's been a really interesting surge of collaboration and work that's gone on there, and a lot of sharing of best practices. So from a policy perspective, what we've done is really said that it's time to be bold, and this is a very unique period in time. And really what we're interested in doing is to ensure that what we have is the ability to really focus on the notion of originating sites getting taken away, that limitation that Joe mentioned, which is this idea of modernizing Medicare. And then we have a few others that we're going after, but I would say that that's one that it was really exciting to hear Senator Alexander say that yesterday in the Senate hearing, that this was one that was going to be a permanent change.
Got it. Well, the results are up of our poll, and we've got about 500 people in the audience. So look at this. What do you guys think of this? Let's start with you, Joe.
Well, I'd say it tracks according to the anecdotal kind of chatter I've heard as I've been able to talk with colleagues around the country. One of the privileges of being in the organization of ATA is people will talk to you. So I've talked to a lot of healthcare providers over the last few months, and I'd say people are in that second bucket pretty regularly. So this mirrors what I've been seeing.
Got it. Now, that makes sense. Most people are scaling up, and very few have a robust virtual strategy in place. Anne, has this been your experience at ATA?
Yeah, we had one colleague who said that of their client base, about 30% really hit it out of the park. And, you're talking about systems like Providence St. Joe's, which brought literally thousands of physicians online overnight. And then they had the other 30% that were scrambling, and that's your ones in purple working on a strategy and looking for a solution. And then a lot of people who are just scaling and really finalizing their strategy going forward. So I think it's very consistent with what we've seen and heard.
Makes sense, and I would imagine this response gives a lot of people comfort who think they may be behind. We're all just working and figuring it out.
We are making it as we go along, yeah.
Absolutely. So let's get into the challenges, because there are a lot of challenges. Let's start with you, Joe. Again, you're in a healthcare system. You're dealing with your colleagues and patients. So what are some of the challenges in adopting these technology approaches?
Sure, happy to address that. I still have the poll up. I don't know if that's everyone else's visual, but maybe I'm not. Maybe I'm atypical. But anyway, the challenges have been really, I think, just doing so much at once. And everyone, on the one hand, the government made a good call allowing people to use any technology in the beginning, FaceTime, Zoom, Google Hangout, you name it. But I think, honestly, that's kind of worn itself thin now. And there's a lot of, I would say, people that are maybe practicing a little bit outside of the zone. So we want to try to get them back into compliance with HIPAA and things like that. So that's a challenge. It's just anybody using Doximity dialer to, FaceTime with their patients. We've got to sort of get that back on track. But and then I think even though both Medicare and as we said earlier, the private payers have all stepped up, there's still a lot of coding confusion. There's still a lot of our people in our revenue cycle operations are kind of having a tough time making sure that we get stuff out and that it actually has the right modifiers. And so it's really, those are all challenges of just scaling everything at once, I think. But the good news before I turn it back over to you is that, and I said this before, but I want to emphasize it. Patients were happy and doctors stepped up, and I think we couldn't really have asked for more given the extraordinary hockey stick growth that we experienced.
Yeah, it is amazing. And Beth, from your time at Humana, your time before that, always spending much of your career in the payer perspective, where have you seen some of the challenges related to adoption?
Well, obviously reimbursement has been a challenge. Payers typically across all of their segments will look to Medicare for guidance. So even for their commercial population. So the fact that some of these provisions were waived, and hopefully after Joe's wonderful testimony yesterday and all the good work that Ann and others have done, we'll be able to see some permanent changes come into effect, and so the health plans can feel really comfortable about opening the doors and allowing for reimbursement for a variety of services.
No, that makes sense. And let's go back to you, Joe. I think a lot of the docs just aren't familiar with the technology, and a lot of the patients aren't aware of that. What's been your experience seeing people adopt and get through these challenges with adoption?
Well, as I said a minute ago, that there's a lot of good news, but we certainly have adoption challenges, and some of them are listed here. I think what we did at our delivery system was we made a conscious effort to integrate a video solution right into Epic so that you can launch a call from Epic, or if you're a patient, you can request an interaction through the patient portal. We do our asynchronous interactions through the patient portal, what we call e-visits. We do e-consults, all within Epic. So those are some of those things we had done long before the pandemic. So we maybe we're more prepared than some. But nonetheless, for doctors in general, they don't like to use multiple screens. They don't like to use multiple tools. So that's been a bit of a challenge. I think more often than not, and as a dermatologist, what we've done is, for instance, a patient will send images over the portal and I'll phone them. But once or twice I did do video calls, and I would say about 50% of the time those didn't work quite right. The patient couldn't get it to work or something, so we reverted to phone. So and again, I think that's all just growing pains, and none of that to me is bad. And again, luckily people are all very, very comfortable with, okay, we got to do this and we'll figure it out as we go. But little things like that. I think when I was giving talks back when we gave them in real auditoria with audiences back in December and January, I was talking to doctors about this and saying, we have to get to the point where this is no longer viewed as an option or a curiosity. And boy, have we got to that point. So we have to look at the bright side here, I think.
And, Anne, from your perspective, thinking about this in relationship to influencing the Hill, I would imagine this whole risk issue comes up a lot about using tools like Zoom, and are we going to breach patient privacy? How are we getting through that?
So as the ATA, we came out several weeks ago with a statement that was pretty clear, that in stating that even though we were rapidly adopting telehealth solutions, that it was important that we did not compromise on quality. And so we've been very clear about concerns about patient security, confidentiality. And I think that that's one of those relaxations that will not stay in place. I think there's general consensus that that's not the right way to go. So there'll be continued concerns about that.
No, that makes a lot of sense. So Beth, payers' perspective, where do the payers see an obstacle with moving forward? I remember working with payers thinking about, oh, these are just more things we have to pay for. We don't want to add anything to the list. So walk us through the perspective of the payer, given the pandemic and our experience to date over the past couple months.
Sure. Anytime anything new comes out, one of the major concerns is, will the utilization be appropriate? And payers have a history to look back on, because when a lot of the pharmacies started putting in the clinics in their stores, there was real concern that people would go to the clinic, but then it would just really result in an additional visit back to the primary care physician. And over time, that proved not to be true, that people actually were receiving the right care the first time. So that's what payers are going to look for. They're going to look for value. They're going to make sure that the utilization is appropriate. And it's not just about overutilization, but so that there isn't, a telehealth visit and then always an in-person visit. But there is a lot of value that can come, because you can divert people out of the ER if they're willing to do a telehealth visit. And sometimes it is absolutely going to be appropriate that after the telehealth visit, they do in fact come into the office, or they do go to another place of service. So they're really going to look at that. The other thing I think that they will really take a look at is ensuring that the outcomes are there and that the appropriate documentation is there. And then finally, what I would say is this is going to be a real opportunity even for health plans to reimagine how they are using these technologies. So as you think about the services that they provide, whether it's a pharmacist helping with medication reconciliation or a nurse in care case management, they're going to look for how telehealth can really add value to those services as well. So I think it's a real opportunity, and I think most leaders at health plans will be saying, how do we go faster with this, and how do we actually find more use cases?
No, great comments. I've been tracking the questions that are coming in from the audience. So I've got a great question for Joe that has to do with this perspective about reimbursement. So one of the audience asked, in light of the fact that COVID-19 has a major effect on lungs, how likely is that respiratory therapists may be included in reimbursement for telehealth in post-acute and home health settings to mitigate readmission? So it's a broad question to ask the question about how about people other than the doctor, and how will we think about reimbursement for that? So as president of the ATA, can you shed a few thoughts about that? And then maybe Beth, you could chip in as well.
Sure. Well, one of the things that when I was had the privilege of being in the congressional committee yesterday, I spoke about was the idea that we need to make sure that other providers are appropriately compensated for their work. And so we'd like to cast a wide net, physical therapy, respiratory therapy, absolutely. Practice at the top of your license, right? That's the lingo we all use nowadays. So we're on board with that. How I don't have any crystal ball as to how our government officials will handle that. That's a big deal for them, and they'll have to score it and all those things that they do, but we're certainly supportive.
Beth, from a payer perspective, how do you think about this? And another question that just came up is, what about fraud? Like, how do we mitigate against these issues of fraud?
Sure, I think you're going to find the payers are going to be all in on this, and they're going to be very, very open to reimbursing for a variety of provider types, because payers want people to be able to stay in their home as much as people want to be able to stay in their home, especially the aging population. And payers have lots of different mechanisms to ensure that the services are appropriate, and they will deploy those and ensure that fraud isn't occurring. But I think you're going to see full support from payers to be able to expand the types of providers that can access the patient population via telehealth.
That makes a lot of sense. Well, I'm getting a flood of questions now that I'm bringing a few of them up, but let's just check into our broader audience again and just ask, as they've thought about investing their IT spend, as they've thought about adopting new telemedicine or virtual care tools, we'll bring up the poll again and ask you, which has been the most important feature? Is it integration into the clinician's workflow? The tool should allow us to customize the solution for your enterprise, be very unique to you. Is having vendor support, because we really need a lot of help getting this started and set up, important? Is it that we want to evolve and constantly add new features? Should that be an important piece? Or, we have had an issue around about call failures. I think, Joe, you actually just illustrated an example of one with your own experience, and is that the most important thing? So poll is up. Please go ahead and register. But let me turn it over to you, Joe. I mean, from your perspective, in having to begin to use more virtual care and having thought about this for a long time, how do you think about the most important features as you start to use new technologies for virtual care overall?
The way I would summarize it is less friction points for everyone involved. This is a great slide, but I don't see a whole lot here about making it easier for patients. And so my heart is always in the patient's corner first. But candidly, what we do at our delivery system is we want to make sure that number one, integration and clinician workflow is probably our most important. They're all important, so it'll be really fascinating to see how the poll turns out. But I would just add another sort of put in a word for making it easy for patients as well.
Absolutely. And I think this call failure kind of speaks to that, but having a tool that's easily adoptable and useful for the patient is absolutely a perspective. And do you have some thoughts about this as you've listened to many of your members and talking about like what they use or can use? What are the features they sort of see?
Sure. And I know that there is general concern about phone only or audio only, that may be most lending itself to abuse, fraud and abuse. And yet I think it is a lifeline for many populations. And of course, one of the things that's really become very evident is the horrid disparities that we have within our society that get reflected in what's going on in healthcare. And so while we may be concerned about the phone, I think we should be measured in our response about when we use it or when we need to roll back that availability. The other thing I would say is that, and Joe made this point earlier, that there is a fair amount of confusion on coding. And so when we think about fraud and abuse, really it's going to be incumbent on all payers to make it as easy as possible and clear and transparent as possible for coding.
Makes a lot of sense. Okay, let's check in and see what our audience thought. Let's bring up the results. Just 1 second, here we go. Interesting. Joe, given your comments and your experience, what do you think of these results?
Again, I thought, apart from number one, which I said, I thought the other ones were kind of an even mix. So I think it's interesting that 0% of people cared whether the vendor could rapidly add features. That's something that actually is important to us. It may have to do with the fact that we've already had the vendor in place and we've worked with that vendor. So we're already thinking about next steps, possibly. Call failure rates, I would have thought might have come up a little higher. So pretty interesting result for sure.
Awesome. Well, let's move on in the interest of time. And I want to talk, Joe, I know you testified just yesterday to the Senate subcommittee. Can you see my slide?
Yes.
Okay, great. I guess I think the transcript just came out from ATA around midnight last night. So I would encourage people to go and read it. It's an awesome testimony you did, but tell us about your experience and where you think this is all going post-pandemic.
Well, I'd say a couple things. One is this was an N of one for me. I've never testified in front of a Senate committee before, so I only know what I know from that one experience. But I will say I was struck by the bipartisan support for our positions. It was almost like I was in a softball situation. Senator Alexander, who's the chair, started off by saying pretty much my comments. So I thought, well, this is going to be easy. So I think they were their staff were well prepared. The whole thing was very pleasant. There was no real hardball questions or people trying to rough us up. Now, all I can say though is, having said all that, and it is very encouraging, I just don't know what will make it into law and when. And of course, we're really concerned about this telehealth cliff. Maybe it's a cute phrase and a good soundbite, but it's true that, in my own case, I'm seeing patients in the office now at 40% of what I did before the pandemic, and I'm doing an extra half day of telehealth. If those telehealth reimbursements go away, I'm not sure what we're going to do, because we can't double book and we can't see people at the rate we did before. So it's pretty important that we get this right.
David, one thing that I would add is that a big change in consumer behavior that's happened as a result of COVID is that now people have real concerns over safety. And so you're going to have a lot of consumers that are really going to be thinking twice before they go back, to the physician's office for something that they believe can be handled over telehealth. So I would really urge people, whether it's in Congress or wherever, to really think about that fundamental behavior change and how people will now really be prioritizing safety up front, and think about it maybe through that lens, which speaks to how important it's going to be to continue with what waivers and so on and so forth have been put in place to date.
Yeah, just to quickly comment on that, when during the pandemic, well, we're still in it, but in the throes of the pandemic, the Mass General Hospital got day after day of positive coverage in the press for all of our frontline workers, and and all good stuff. And now we're known as the COVID hospital. So we just did an ad campaign to remind people that they can come and that we'll treat them and we'll keep them safe. So it's what Beth said is a real issue for us.
Mhm.
You know, again, we're getting a lot of questions about this particular slide, and one of the questions is, you know, we've said that HIPAA is relaxed for a few months, and from your perspective, crystal ball here, can you get a little specific about what we might expect going forward?
So I think 1834M, the originating site, again, Senator Alexander summarized it at the beginning and called it out immediately. I think the second is there's general agreement on HIPAA, the relaxation, that's not going to stick. I think the third that we're pushing for is the ability to, for Congress to give the Secretary, HHS, the flexibility to expand the list of eligible providers, and HHS and CMS should maintain the authority to add or remove eligible telehealth services as supported by data and that are demonstrated to be safe and effective and clinically appropriate, and really go through a process that's very transparent and very predictable, if you will. So I think the last area that we have not touched on that was a real win was that federally qualified health centers and rural health centers are able to provide clinical services using telehealth. They were not allowed to do that before. And so, again, we talk about regulation catching up with technology or modernizing Medicare. I mean, this is really a lot of what happened. We saw what telehealth and technology can use to reimagine care and really improve lives across the board or make people safer, keep them safer. So I think the crystal ball and the aspiration is that that's going to stick.
Well, you know, it's been an interesting experience for everybody for sure. And I you know, Joe, you're a dermatologist. As you can see, I have a little bit of a risk for sun exposure. So, you know, and I recently had some concerns 3 months ago, and I actually thought, geez, what if I just took a picture with my phone and sent it to my physician? And I actually had a great experience with my dermatologist who reassured me everything was fine. But, you know, now suddenly, because I have a routine primary care visit coming up, I don't want to do everything virtually that I can. So we see here, I pulled a couple surveys, and 77% of patients are very keen to experience virtual care encounters. How are we going to navigate our way through this, Joe?
I try to make it as simple as possible. This did come up yesterday, and I tried to steer the legislators away from legislating this particular point. And this, in essence, it's really up to the physician to assess what he or she needs in terms of data to make a diagnosis or change a care plan. And if that can be obtained without touching the patient, then I think we're good to go. If you either have to do a physical exam maneuver that you can't recapitulate with your camera, or they need some sort of test or procedure, they're going to have to come in. But I think we can cast a pretty wide net comfortably, but we as doctors have to be the ones to think that through. And again, my experience before this was that I never got docs to even start to think about it that way. They would just say, oh, no, my patients want to come to the office, or oh, no, I can't do that. Now, all of a sudden, we're engaging with them, and they're saying, you know what, actually, for someone with an x-ray that just got an x-ray or a PET scan or whatever, I can call them and go over that without them coming in. So we're getting there. And I think that's as simple as I can make it in terms of that.
Well, you know, I like, go ahead,
David, I would just add that historically we've had a bias towards physical presence. And what has been very clear is that, and physicians, I think many have been very pleasantly surprised that that's not a necessity, that there, as Joe indicated, there are many indications, many circumstances where that's not necessary. So that bias is getting chipped away.
No, I agree. You know, it's funny, as a practicing primary care physician myself, I was always struck by the amount of friction in healthcare. You know, you have to make an appointment. It's scheduled, as the last bullet here says, and average is, according to one survey, 24 days ahead. you have to take a day off or a half a day off of work, and in a car, drive, find a parking space, go in, wait, sometimes get a paper clip with an additional form to fill out to get, and then follow up. I walk out of the room and I forget, even as a physician, what my physician said. And I historically have not felt comfortable following up with asynchronous. So it's a lot of friction. And I think if we look ahead and talk about some stories that we've all experienced, I shared one of my own, and Joe, you as well. We've had a number of different aspects where folks have reported some improvement. Beth, I know you had one experience here around focusing on seniors from a primary care perspective.
Yeah, right. And I'll share two things very, very quickly. One was I had the opportunity to speak with a gentleman who's in charge of a very large primary care practice that works mostly with seniors. And within 2 weeks of shutdowns, they were able to convert 70% of their in-person visits to telehealth, to high satisfaction for both them and for their patients. And then the second thing is not to forget about all those seniors that are in skilled nursing facilities or assisted living facilities, many of whom are still in lockdown, and physicians can't get in, and those facilities don't have telehealth. So you really, and you have people then that are leaving the facilities to go to the doctors for, routine checks or whatever. So I really think that there's a tremendous opportunity here to really ensure that people are getting the right care in a place that's safe for them. As you think about, as we go beyond COVID, think about just a typical flu season as well. If somebody's 90 years old and it's a routine check, you're probably going to feel much more comfortable having your loved one stay in their facility and being able to do something through telemedicine. So I think more and more people will start to really think through these use cases, and I think you're going to continue to see the benefit.
Anne, can you share a story or two of what your members have been experiencing in terms of using virtual care?
I think that in addition to all these great stories from members of the ATA, Cleveland Clinic, Northwell, UPMC, what we've also seen, for example, at Children's National, one of my favorite stories is early on in the crisis where the pediatricians were divided between those who were doing in-person screenings and care and those who are manning the computers, if you will, and doing virtual visits. And one of the clinicians, who was an older lady, but incredibly skilled and very respected, had always been a naysayer about telehealth. And she started doing telehealth visits and found that just sitting across and speaking with the parent was very reassuring for the parent. And she could really assess a lot with her patient, even if they were just crawling all over the parent during the course of the visit. So she became a big convert and a big proponent. But likewise, we ran up against this unintended consequence of what was going to happen with well child vaccines. And so there's been a lot of interesting and important innovation at Children's Dallas, at MUSC, in private practices where they're maintaining the well child vaccines, because we don't need a measles epidemic on top of everything else, right? So there have been really tons of innovation. And then you have organizations like Vivify and Amwell who are providing remote monitoring for first line responders. So making sure that they're staying safe in New York as they are actually dealing with populations. So really interesting, and it's inspiring, truly.
No, I have to share this story because Northwell is up here. I was talking to Michael Dowling the other day, CEO at Northwell, and he was very clear. He said, in the old days, meaning before 3 months ago, if I wanted to expand my hospital beds by 200 beds, it would have taken me 4 years. I would have had to create a proposal, they'd form a committee, they'd submit a budget, my CFO would push back, we'd do it all again. Instead, it took me 4 days. So his last comment was, we are not going back to the way we used to do things. So I think there is some concern people will keep moving forward, and others have had a financial hit, and will have a different experience.
Yeah, no, absolutely.
So I think what is clear, and I think Beth, you spoke to this a bit from a payer perspective, there's an opportunity for a huge amount of potential savings, right? If we reduced all that friction, but there's concern about whether the utilization would be appropriate, as you pointed out. How do we think from a payer perspective of how we start leveraging the potential cost savings here and really take advantage of this opportunity?
Sure, and obviously savings are a good thing as long as the outcomes are there, and obviously I believe strongly that that'll happen. But think about this: when there's that potential for savings, then that goes right back to the consumer in the forms of lower cost share, lower premiums, helping to make healthcare more affordable to patients. So that's really important. So the more that we can do that, the better it is for everybody.
So much opportunity here, and you know, you are at ATA in a wonderful position right now, and I would imagine extremely busy. So just share us a little bit, and then I'd like Joe and Beth to chip in, because you're all involved with ATA. Just you know, what is ATA doing, and how does it think about its members and its work?
So we are lucky because we have an incredibly diverse and broad membership base. We have obviously a very engaged and dedicated board. And so a couple of things that are worth noting. One, I'll put in a shameless plug for our annual meeting, which is next week, June 22nd to 26th. And it's going to be virtual, and it's an amazing program. So we were supposed to have an in-person event in May and ended up making a decision in March, really worked in a deliberate fashion with our members in the process. So I think the annual event is going to be very exciting. The second thing, though, is that we are trying to equip our members, as we always have, with the tools and resources they need to be effective in their implementation of telehealth. So I've had a number of webinars, for example, coding in the age of COVID, you know, how do you get paid for this stuff? You know, how do you scale ICU beds, any number of different topics, and those have been broadly available to the public, and people continue to listen to those. And then the third thing, which is I'm very excited about, is for us to organize and galvanize our members around this very unique period of time. And we've launched a campaign to really cement the gains, to ensure that what has happened is sustained going forward from a regulatory and legislative perspective. So that involves policy and advocacy at the federal and the state level, and then also really working on media and thought leadership so we can demonstrate that we've anticipated the questions and concerns that legislators and regulators have had, that we also have demonstrated through data, through research, through other work, that fundamentally telehealth digital services are good, and that we've won the hearts and minds of clinicians and consumers. So it's a very exciting effort.
It's exciting. Joe, your perspective, you're president, you're obviously committed here.
Well, I've been around the block. I was president in 2004, so they invited me back to get it right the second time. But I tell you that during that era, it was really mostly an association of academics who were trying to build a new industry. And now we have, it's what's most exciting, other than the fact that we have, everyone knows what telemedicine is now, is that we have such a broad and diverse membership. And it really is a place where anyone who cares about the industry can come and be represented in a very, very transparent way. And it's really a pleasure to be part of that, watch that grow under Ann's leadership.
No, that's great to hear. You know, Beth, having myself worked on the payer side for a long time and worked on a lot of these committees thinking about standards, and one of the questions that came in from the audience is, will there be an effort, or should there be an effort, to develop common codes for reimbursement across payers? Because currently, I believe it's still a little bit payer dependent on the coding use.
Sure, and part of what has transpired so far with many of the members within the ATA is that they come together and they help create best practices, guidelines, standards that then we are able to share back with the regulators. And so the one thing that I would say to folks that are participating in this webinar, whether you're with a provider system, a payer system, you should be at the table. And being a part of the ATA really allows you to have a seat at the table and really be able to express your voice and bring your ideas forward. And so I do think that it's really, really important to be able to do that. And whether it's around payment practices, reimbursement, so on and so forth. But it really is an avenue for just a cross constituency to come together and really help shape the future and shape policy.
That makes a lot of sense. Well, here's another question from our audience, and I'll just open it up to whoever wants to take it. Should we return to CMS's methodology of using non-facility RVUs, such as with place of service 0.2?
Joe, anything?
Yeah, so that one is, I think, probably detailed enough that I can't, off the top of my head, give a crisp answer. I'm going to probably punt on that one.
Yeah, no, that makes sense. So I think the bottom line is we've had a historic way of paying for these services, and given that there has not been adoption, should we rethink from a CMS perspective about how that should be done? And I think the answer is probably yes, and I think Beth made some good points about bringing together people to drive those kind of standards with the politics of being on the Hill. Great. Well, this has been a great discussion around ATA, and I really applaud the work that you've been doing. And I understand that you can even offer a discount code for the attendance at the conference next week. So that's exciting.
Cool.
So we'll follow up with that. Just, I was talking about the friction. I'd say a little bit about the thoughts that we hear at Innovator. I know, Beth, you've been an advisor for us here. All of this detail I talked about with friction, making an appointment, getting to the office, taking half a day off, we can really reduce a lot of that. So, and we can add value. We can start prior to the e-visit, begin to do some triage, some assessment. If you're a care manager, do outreach to get the e-visit in place. During the e-visit, we can really have a meaningful virtual exchange, including visual, maybe even three-way with primary care and specialty. And if it's a chronic care patient, in a population health contract, start thinking about remote monitoring for blood pressure, scales for congestive heart failure, and social determinants are such a huge issue. Thinking about how do we then connect with the communities, right? And how do we help identify and deal with so people are aware of those social vulnerabilities, and then obviously do that after visit follow-up, where I always forget, even as a physician, what my physician said or questions I forgot to ask. Joe, I'd love for you to comment on this issue of social determinants of care. And physicians have historically not thought about this and connecting with community resources. How do you think this future of virtual care might help identify and leverage the social determinants of care?
Well, I'd say a couple things. That the pandemic certainly laid bare a number of disparities in the way we take care of our patients, and everyone owns a piece of that, and I think we're working as fast as we can to try to change it. The telehealth itself is a tool. Telehealth isn't really responsible for disparities, and in some cases, people maybe brought them to mind because they don't have broadband or they can't afford a smartphone or a tablet. This is one of the reasons that we're quite eager to have the health plans and the government continue to pay for telephone interactions with our patients, because it really helps us with this underserved population. And we can do a lot by telephone. We can't do everything, but there's a tremendous amount we can do. So those are some thoughts on the matter.
And I know, Anne, both Anne and Beth, historically, home health has not been well reimbursed or well leveraged. How do we think about including home health in terms of virtual care and our movement toward value-based care?
From my perspective, it's a must-have. Seniors want to age in place. Payers want them to be able to age in place as well. And there's just a tremendous opportunity to really be able to leverage telehealth to do that. And the one thing that I would just share with individuals is, as you're thinking about reimagining healthcare, channel your Steve Jobs. I think Joe said this earlier, really up from the customer experience, making it as simple and easy to use as possible. And then just reimagine what you can use it for, well beyond just the traditional physician-patient visit. There's just so much opportunity here to really change the face of healthcare as we know it.
Yeah.
No, I think that's a great comment. Anne?
I would just add that, again, I thought one of the most significant developments in this sector was when Best Buy acquired Great Call in December of 2018. And you reimagine Geek Squad coming into your home and making it easier for you to age in place. So I think the idea that your home is going to be the exam room of the future is really a driver. I think that the whole advent of monitoring and all the devices that can be used to help keep people safely in place, to convey data and information to their caregivers, I think that is just going to be fun. It already is taking off, and it'll be phenomenal.
That's great. I know we've really leveraged this here at Innovator and thought about the components of a virtual care platform broadly for us, because we do believe home is the new setting for care. And we think about it as, seamless televisits, being able to use high quality audio and visual, having virtual care coordination, particularly for those chronic patients that you want to connect with their care manager, and community health agencies around the social determinants. How do you automate office workflows using telehealth and these other virtual care so that we get more efficient? And I think to Beth's point is, how do we think about improving not only utilization, but also the cost of care, gaining the value that we can, and then being able to monitor these readings in real time. I know I used to take care of a lot of patients with blood pressure, and once a year visits, with once a year checks on a blood pressure is not ideal. Getting more real time and regular monitors of all the different aspects of care, and being able to generate insights and leverage artificial intelligence and all of this capability we now have with technology. And I think, Joe, as you said, let's move us into the 21st century. I love that comment when you were in front of Congress. So, first of all, I want to just let the audience, we'll follow up with a little information of what we're doing here at Innovator, and we often offer a free 30-day trial to get people used to it. But Joe, how do we move into the 21st century? How do we get there? Let's get there now.
Well, we're at a really, we're on the one hand, we've made enormous progress in a couple of months, and yet we're still at the ground floor, because what we really need to have when we're done with this journey is a complete integrated digital and analog experience. So many other services that we consume now, we just expect that, whether it's getting a ride from Uber or getting food delivered to our door or what have you, and we have to go there in healthcare. So imagine that your first interaction is going to be with a software bot. You may or may not need to even go to see a provider, but let's suppose that the bot determines that you do need a provider. They'll triage you and decide maybe it's virtual care, maybe it's urgent care in person. And here are 5 urgent cares near you, and this one has a 10-minute wait. You get the idea how this is going to work. That's where we're all headed, and it's such an exciting time to be watching and riding that wave.
Absolutely. Anne, closing comments?
The best is yet to come. I think it's exciting.
I love it. And Beth, what do you think?
Perfect opportunity to reimagine healthcare.
Great. Awesome. This is so exciting. I just want to thank all 3 of you, because we've been able to take questions along the way, so able to tackle that. And great answers. We had great participations from all 3 of you. Thank you very much for participating. And I want to thank our 500-ish audience members for spending the time today with us today, hearing about the ATA, hearing about what we're doing in Innovator, and most importantly, thinking about how do we move forward, as Joe said before the Senate committee, moving into the 21st century. Let's get there. So exciting.
Thank you.
Thank you again very much, American Telemedicine Association, now the ATA, Innovator. We all thank you very much for participating.
Thank you.
Thank you.
All right. Thank you very much. This concludes the webinar.